I'd like to cover 3 important studies that are California specific, give you a little bit more flavor for the detail and the rigor that goes into these studies to give you some idea of how much you can trust the results. The first is the American Cancer Society study, which we've heard a number of our speakers discuss already. Next is the California Teachers Cohort. And then finally is the Seventh-day Adventist, the so-called ASHMOG study from Loma Linda University. Next, please. So for the American Cancer Society studies, we have 2 studies that I'll present. Both have long-term exposure estimates for California-wide and Los Angeles studies. They're both based on the American Cancer Society Cohort Cancer Prevention 2 survey. And one of the real strengths of this study is that we have the capacity to control for an extensive array of confounders. So we have 20 individual confounders as well as 7 indicators of neighborhood poverty and income and other things that have been widely associated with health outcomes and mortality in the United States. Next slide. This just gives you a list of our smoking variables, 13 in every single model. Next, please. We include educational variables, marital status, body mass index, alcohol consumption, which have all been associated with health outcomes. Next. Occupational exposures were extensively assessed by Mark Goldberg and Jack Simeon-Ticky, 2 leading occupational epidemiologists, with a dirtiness index based on over 150 occupations. So we have an indicator variable that measures occupational exposures to particulate matter and carcinogenic risk potential. We also have indicators of diet, so fat, fiber, citrus. Many of the major food groups that are known to affect health are included in every one of our models. Next, please. The exposures for the Los Angeles study were based on available government monitoring at 23 sites, and we developed a land use regression model, which essentially uses these sites as a dependent variable and uses adjacent land use and traffic and industrial output as predictors. And what we see here is a large gradation in air pollution across Los Angeles that follows patterns to what we might expect. Higher along highway corridors, higher near the ports of Los Angeles and Long Beach, and higher in the inland areas. The exposures that we'll be using for the statewide study are based on a kriging model, and this is a way of statistically making our best estimate between the monitoring sites, because there are 72 of them available in California, but we want to assign this to many more people, so we need a way to statistically assess the best values between those sites. I can say from spending months developing this model that it fits the data very well and can reproduce predictions at sites that are excluded with a high degree of accuracy. We see a pattern in California that's important for interpretation and well known, higher levels in Los Angeles and in the Central Valley, and to some lesser extent in the San Diego region, and lower levels in the coastal areas of Central and Northern California. The LA study used zip code level data, which is what we were permitted to use at that time, for nearly 23,000 subjects. For the statewide analysis, for the first time, we've actually gone back and geocoded their home address. So we have a much greater level of precision about where they live. And in both cohorts, we follow them up from 1982 to 2000. And in the statewide, we have about 22,000 deaths. So fairly substantial number of deaths to deal with for a statistical analysis. We use a Cox survival model with allowance for clustering in the zip code area. One of the key things about statistics is we're assuming our observations are independent. And if they're not independent, we can't trust our significance tests. So we've gone to great lengths to make sure that the data are corrected for any non-independence by proximity of where people live or different regions of the state. We've conducted analyses to look at clusters at different geographic scales beyond the zip code, so we've looked at air basins and counties. And we've also included a longitudinal or a latitudinal term that measures a north-south gradient to see whether or not there's any residual confounding that's due to this broader trend of north-south differences in culture and economy. We also tested a number of other pollutants in the models and test them as co-pollutants. So this is sort of a crowded slide, but I wanted to include it just to show you the modeling process that we generally go through. We start off with just the PM variable. This is for all causes of mortality. It's a relative risk over a 10 microgram increment in exposure. And we can see that there's about a 20% increase that's elevated, highly elevated above 1, statistically significant when we just put PM in the model for all causes, and about a 41% increase for ischemic heart disease. As we start to put in individual level covariates, those 20 variables that have 44 terms that I talked about earlier, it takes down the pollution effect, as we might expect. We put smoking in. Smoking is a major determinant of health that may also be associated with air pollution exposures, because people of lower socioeconomic status tend to have higher exposures and they smoke more. So we see that that goes down. And then we put in this array of many, many other variables at the neighborhood scale, and we get a fairly stable estimate, which comes down to probably our best estimate, which is including 6 of these variables, and we can see that we've got a nearly 13% increase in all-cause mortality and about a 26% increase in ischemic heart disease. It's robust to inclusion of different measures of other pollutants, as well as the proximity of freeways to the subject's home. So convincing evidence that it's not confounded by a wide array of variables that we know can predict health and could associate with air pollution. This is from the statewide study, and this is against the interquartile range of about 8.5 micrograms per cubic meter. These are percent increases in mortality. And we don't see in the statewide assessment an elevation in all-cause mortality in relation to particulate matter, but we do see this pattern that's been observed in numerous other studies that Arden Pope brought up, that cardiopulmonary mortality, cardiovascular and ischemic heart disease, they order. So as we move from less to even more plausible biological endpoints, we see larger effects. And we see an elevated effect for respiratory mortality, but we don't have a lot of sample here, so it's not significantly elevated. So we've tested for latitude, county clustering, and ozone as a co-pollutant, and these results stand up. So they are slightly lowered when we include ozone, but they're significantly elevated. We started wondering, well, why would we see such high elevations in cardiovascular disease, but not high elevations in all-cause mortality? Well, if we look at our 22,000 deaths, close to 10,000 of them are coming from cardiovascular disease, but there's another 9,000 from other causes, and the dominant cause in that other grouping is cancer. And what we see is when we take cancer out of the all-cause, we see a risk estimate that's very similar to what Dr. Enstrom got, about 4% increase. And we have to ask, well, what does cancer have to do with it? Next slide. And this is a map. You can think of this as the mortality that we weren't able to predict with our individual level variables like smoking and alcohol consumption. And what we see is that after we apply all of those individual variables, there isn't much residual variation left in the cancer outcome where we have the most pollution. So our model is predicting these outcomes very well where we have a lot of pollution. We haven't honed our statistical models to look at cancer outcomes because we've been focused on cardiovascular mortality. I think we probably need, these are preliminary results, we need to go back and to include things like family history of cancer and other variables to get a better assessment of why we're seeing this negative association with cancer. But we do understand why we're getting a null result for all cause now, and it's because we do see this negative association with all cancers. Thank you.